Next slide. I actually just heard this statistic in the last 2 or 3 weeks, and I was astounded that it was this much. In the United States alone, we have a maternal death every 12 hours. That is just unfathomable to me. I just cannot believe in our country that happens. And the 2 major causes of maternal deaths that are truly preventable are hemorrhages, and that's for the most part, and hypertension. Next slide. So what do we consider as severe hypertension? So it doesn't matter if the cause of this is from chronic hypertension and they're uncontrolled or they haven't taken their medicine, or it is from hypertension with superimposed preeclampsia, or if it's just straightforward preeclampsia. The numbers don't change. So if a patient presents to the exam room and has a blood pressure of 160/110, then we should repeat it in 15 minutes, and then if it is persistent, same or above, then we should treat that patient. If a patient shows up to the exam room and their blood pressure is greater than 180/120, then what we should do is start treatment immediately. Now, if they show up and their blood pressure is greater than 240/140, then we should call whoever we call in our hospital, like I would call a med on this. It's a medical emergency treatment team. And I would tell them I've got a patient with blood pressures of 240/140 and I need her evaluated and to see if she needs to go to the unit. Other people might call their hospitalist to ask them for help. But a patient with that severe hypertension, you're highly unlikely to get it controlled on the floor. Now, how fast to treat blood pressures and when to get it, how fast to treat blood pressures and what is our goal are 2 important answers. Steve Clark looked at the obstetrics network, and they do something like 20,000 deliveries a year. And once they started treating their patients within an hour for severe hypertension, then they had no cardiovascular events or deaths. And so it's kind of that standard for which we live by. So please try to get it done within the treatment started with 1 hour. Now, what should be our goal of our blood pressures? If I see somebody 160/110, I'm very happy with them around 150/100. You know, the main thing, you do not want to totally correct them to like 120/80 because the circulation in the brain, the maternal brain, can go down, okay, and cause problems for the mother. And with the fetus in there, you cannot drop the blood pressure too low or else the baby will start decelerating, okay? Same thing for 180 over 120. Do not totally bring that down less than 150 over 100, because if we do bring it down too fast, what ends up happening, not only the maternal cerebral blood flow, but the blood flow to other organs like their kidneys, maternal kidneys. You can cause acute kidney injury if you lower it too fast. Too low. Next slide. Sometimes when I do these slides, I'm thinking, everybody knows this. OB doesn't change for 50 years, and we're using the same medicine that we've always used. When I was in residency, I preferred hydralazine. Was used to using hydralazine, but as I've gotten older, and I think most people now are training individuals to start with labetalol. Labetalol actually has less adverse effects. Primarily, we avoid unsuspected maternal hypertension, and we also have less abnormal fetal tracings. So labetalol, and the main thing is, remember, do not use this in an asthmatic or patients with bradycardia or heart block, or someone who has terrible heart function and congestive heart failure. But the way I tend to use labetalol, I go 20, 40, 80, and then 80, okay? And that gives me 220 milligrams of labetalol. And I space it, the onset of action, it's much quicker than hydralazine, but it peaks at 10 to 20 minutes. So I don't want to escalate that more than every 20 minutes, okay? And if I'm starting to bring down the blood pressure and into a range I want, then I might not repeat it for 30 minutes, okay? So 20, 40, 80, 80. Now, you can do one more 80 milligram dose for a total of 300 milligrams, but I have found that if I do 80 once and 80 again, if they are not responding, then I move to hydralazine. Now, hydralazine is a 5 milligrams IV. I start with 5 milligrams first because I don't want the fetal heart rate to bottom out with me. Now, one of the mistakes we make as providers, because we get anxious, is that we dose hydralazine too close together. Sometimes we say in 15 minutes, we give more hydralazine. And hydralazine, we should wait for at least 30 minutes because the onset of action is not until 10 to 20 minutes, okay? So just be careful because you can get a compounding effect and cause hypotension. Now, when do I use nifedipine immediate release? Okay? Nifedipine, you cannot, and remember this, please do not use nifedipine sublingually, okay? You will drop their blood pressure, and actually, when it first came out, a lot of people had strokes in the emergency room because they got sublingual nifedipine. So, you use nifedipine immediate release. Now, what we tend to use in our outpatient setting is nifedipine XL. So the very first question is, why do we change from XL to nifedipine immediate release? The reason that we change is that the onset of action for XL is 4 to 6 hours, and so it's a lot slower process to lower blood pressures than nifedipine immediate release. I start with 10 milligrams, and if it isn't lowered in 20 to 30 minutes, then I add another 10 milligrams, okay? If it comes within the area or the time that I'm looking at, the blood pressure control that I'm looking for, then I just keep the patient on nifedipine, usually every 4 hours, okay? The maximum dose of immediate release nifedipine is actually 180. So I use nifedipine in 2 situations. First, I use it for patients who come in who do not have IV access. Some of our preeclamptics are, they're morbidly obese, and then they've gained 40 pounds in the last, 3 weeks, and we simply cannot find, we simply can't find veins on them. And so we don't want us to, try IVs for 2 or 3 hours. We want us as providers to be able to give them an oral medication. If I have somebody, the second time I use it, if I have somebody I use labetalol on and then some hydralazine, I will start nifedipine later in the day to give them a drug that is in their system that will help control their blood pressure. Because if you use 220 milligrams of labetalol, you've used 10 milligrams of hydralazine, when those drugs wear off, the blood pressure is going to come roaring back. And if you got nifedipine on board, it helps lower the blood pressure. Next slide. I think that this is the most important slide in our entire slide set today. So every hospital, okay, if you have an obstetrical unit, by now should have standing orders for severe interpartum or postpartum hypertension. So say I am on call today from my hospital and I'm out on the golf course, which I don't play golf, and I don't hear my beeper. So they give me 15, 20 minutes to call back, and I still haven't called back. And so they page me again, and my phone's on the little golf cart, and I still haven't heard it. And, or it might be in the middle of the night, and I'm human. I may not hear the beep until maybe the 3rd time. So all hospitals should be able to treat severe hypertension without a physician's order. And you can, it doesn't matter what you do, okay? You can say, well, I really don't want my nurses giving IV meds without me in the hospital. Well, it's okay to write a protocol for nifedipine, because the main thing is try to get the drugs in less than an hour and the blood pressure lowered in less than an hour. Next slide. So the only tips, I've already given you one of them, actually two of them, is about avoiding blood pressures less than 140/80. We need to remember that an epidural, if a patient's in labor or we're getting ready to set her up for delivery, an epidural lowers the blood pressure by about 15%. So if I've got her around 140/90, and I'm going to give her an epidural, I don't want to keep adding IV drugs to that, because the epidural is going to decrease the blood pressure alone. And then you can start oral medications like the nifedipine, immediate release, or we start labetalol too, as an oral medicine that we use after the initiation of the IV medication. And basically, the bottom line, the takeaway message is OB's the same. One, treat with 1 of 3 drugs and treat within the first hour of the patient being there. Have an order set that the nurse on labor and delivery can do without the physician being there. And the other thing I forgot to say is immediately the baby should go on the monitor, and we should see the health of the baby when we get a patient in with blood pressures like that. So I'm happy to entertain any questions y'all have.